Hello, everyone. My name is Eleanor Klibanoff. I'm the women's health reporter at the Texas Tribune, based in Austin. This is session number 4 of the Rural Health Workshop. And this session is focused on rural reproductive health care access. As you all likely know, the whole country is suddenly paying a lot more attention in the last couple of years to reproductive health care access more generally, which is a long overdue conversation, in many parts of the country. It is especially overdue in rural areas, which have been struggling with workforce shortages, hospital labor delivery unit closures, and adverse maternal health indicators long before the Dobbs decision. A lot of what we're going to talk about today are things that, have already been discussed in other parts of this workshop about, the same issues that plague maternal health, have plague other parts of healthcare as well, especially workforce shortages and hospital closures. But as we will talk about, when rural communities when healthcare systems face hard times, labor and delivery and maternal health care and women's health is often the first thing to go. And that begins to impact the whole healthcare system across the board. So very excited to be moderating this conversation between two leaders in this field. I'll go ahead and introduce them. We'll jump in. And we do want to leave a lot of time for questions. So we're going to talk amongst ourselves for about the first 30 minutes and then turn it over to you all for your questions. You can submit questions at any time in the Q&A space, and that's where we'll be asking the questions from. The chat we'll reserve for talking sort of amongst yourselves and sharing some links and things like that as we go. So to start us off, to introduce our panelists, we have Dr. Adrian Billings, a full spectrum family medicine physician, chief medical officer at Preventative Care Health Services, a federally qualified health center where he practices in rural Alpine, Preventative Care Services is in rural Alpine, Marfa, and Presidio, Texas, along the Texas-Mexico border. Dr. Billings is also Associate Academic Dean for Rural and Community Engagement at Texas Tech Health Sciences Center, Permian Basin. And Dr. Julia Interrante is a research fellow and statistical lead at the University of Minnesota's Rural Health Research Center. Her research examines the effects of policy on maternal health outcomes and on access to maternity care services, with specific focus on geographic and racial equity. Thank you both for being here with us today. Dr. Billings, why don't you start us off and tell us a little bit about your own personal journey to becoming a, delivering babies in the Big Bend region and sort of what maternity care looks like for your patients in your corner of the world.
Sure. Well, again, thank you so much for the privilege to speak to you all, and thank you for this invitation, and thank you for the opportunity to talk about kind of the joys and the challenges of women's healthcare access. And thank you all to what you all do. My understanding is that this is a diverse audience of nonprofits and journalists, and thank you for your advocacy on behalf of our rural populations. So I'm a rural student, or I was born and raised in Del Rio, Texas, along the Texas-Mexico border, about 200 miles east of where I have been practicing my entire career as a physician. And I was delivered by a family physician, and he ended up taking care of me into college and did all my well visits and my sick visits. And when I had exposure to rabies, he took my call on a Saturday morning at his home when I learned of my rabies exposure. And so I went to medical school to become that rural doctor that took care of me, and became a family medicine physician, and have really seen it as an incredible privilege and a blessing to be able to provide healthcare in rural areas. And I've been practicing there for 17 years now, and have been blessed to have incredible patients and incredible colleagues and healthcare workers that work with me, and really feel that this community has taken care of me as probably more so than I've tried to take care of the community in the region where I live. So I tell trainees that I love what I do, and if I had to do it all over again, I would do it all over again, to go to medical school and become a rural family physician. So thank you.
Thank you. And tell us just a little bit about, like, for your patients, I mean, like the scope of the area that you serve and sort of the scope of services that you provide and end up providing?
Yeah, so we are just a geography lesson, perhaps, for those of you who do not know where Alpine, Marfa, and Presidio are. Alpine, which is really the central hub for medical care in the Big Bend region of Texas. Alpine is 210 miles southeast of El Paso and 160 miles southwest of Odessa, Texas. And Alpine is about 100 miles north of the Mexican border, and we're in a region of far west Texas, or the Big Bend region. And we have very limited healthcare workforce from the associate's degree all the way to the professional or terminal degree. We are a health professional shortage area, and we are considered a frontier health professional shortage area by the federal government, meaning we have limited population density and very limited resources. So there is a critical access hospital, which is a 25-bed hospital that is 60 miles away from the nearest similarly sized hospital to our north. And we have a labor and delivery unit, and we deliver about 200 babies a year. But our women come as far away as Candelaria, Texas, which is a 150-mile drive one way for those women to access labor and delivery services. We have a federally qualified health center that I've been a part of my entire career and serve as the chief medical officer, where we provide health care to anybody, regardless of their ability to pay. And we're supported by the federal government to help support indigent health care. And we provide everything from dental care to behavioral health care to primary care, including prenatal and postnatal services. And several of our physicians provide labor and delivery services as well, including some gynecologic reproductive health care access for these women. And then, of course, we provide the postpartum care, and we, as family physicians, we usually end up taking care of the babies afterwards. And I also serve on the school board, and I have 17-year-olds that I'm now asking if I can hand them their high school diploma when they graduate this coming May. So that's kind of our practice in our region.
Thank you. I appreciate that. Dr. Interrante, maybe you can sort of help us put rural communities like Alpine into a national context about sort of the challenges and the unique challenges of providing maternity care and labor and delivery in rural areas.
Yeah, so at the University of Minnesota Rural Health Research Center, all of our research is really national in scope. Again, so looking at what's happening across the country around rural maternity care access, using what limited data sources are available, which is one of the issues we might get into later as well, and also just trying to look at bigger trends and pictures of what's happening to tell the story and to provide those data points for policymakers to help improve some of these situations. So providing maternity care has a high fixed cost. There are issues around paying for staffing, equipment, training, facilities. Babies come when they come, right? So you need to have staff ready and available 24/7. And when you're talking about a rural community where there's only maybe one or two or a handful of clinicians who are attending those births, that can be quite challenging. We also have a lot of rural communities with pretty low birth volume. As Dr. Billings said, his hospital system has about 200. We see that in a lot of rural communities where it's well less than 500 births, some even as low as 100 births a year. And the way that our healthcare system is set up, we pay on a per volume basis. So that can create a lot of challenges. If there's any economists here, we're thinking like economies of scale and what that looks like, right? So high fixed costs, low birth volume, and payment that's based off of birth volume. There's also like I mentioned, workforce concerns and also some safety concerns when you have few births that you are seeing, and there's always challenges with maintaining clinical skills when you have that low birth volume. But again, I think a lot of these issues are really products of the current policy system that we have set up. We also know that hospital financial distress is a leading predictor of rural hospital closures. And when hospitals are facing financial difficulties, they often start with closing obstetric services in an attempt to save money because of those issues I mentioned earlier. They see it as a relatively unprofitable service line in places with few births. And again, this is really a product of our the policies that we have in place that make that so challenging.
Right, right. Thank you for that. Yeah. I mean, Dr. Interrante, maybe you can talk a little bit about, I know like the United States already has pretty staggering maternal mortality rates and a whole host of problems with maternal mortality, morbidity, maternal health, indicators sort of leading to that. What do we sort of know about the impact on maternal health and health outcomes with rural labor and delivery closures, or like when people have to travel further distances for prenatal care and delivery?
Yeah, so we know generally on average, maternal morbidity and mortality is increasing in the US, and it's even more so in rural communities and in urban communities. And again, it's not random where this is happening. Risks are higher in rural communities with a higher proportion of patients who are Black, Indigenous, and people of color. Areas where a higher proportion of patients are lower income and are thus Medicaid recipients as well. And again, there's challenges for distance and travel, as you mentioned. So we know that there are some known risks that are associated with the closure of a local obstetric unit. We have seen that there are slightly higher risks of preterm birth. I think this is associated with some things around, again, accessing prenatal care and all the care leading up, even preconception care too, which I think is also an important aspect here. Also higher rates of out-of-hospital births, and this could be things like planned home births, but also unplanned ones where people on their way when they're driving really far to get to where they're planning to give birth, and baby comes early, The largest increase that we see is births that are occurring in hospital emergency rooms in places that don't have obstetric services. Some of those had them in the past and lost them, and some hadn't had them for a really long time. And again, as you mentioned, the greater travel distances. So most rural residents do give birth at rural hospitals, and outcomes are generally good for those patients. And giving birth locally is meaningful and important, but we do see increasing risk the longer that patients have to travel to have their birth, both for maternal and infant outcomes as well. We see much higher rates of NICU admission for patients who have had to travel farther to give birth. So yeah, that's some of the risks of obstetric unit closures.
Thank you. Yeah. Dr. Billings, as a frontline provider, I mean, how does that sort of align with what you're seeing? And I guess, like, how is the prenatal care and the pregnancy care that you're providing different than if you were a doctor in Dallas or closer in?
Yeah, I actually absolutely agree with Dr. Interrante's and her, objective and academic assessment. That is, so true. If I was a family physician in Dallas, I likely would not be delivering babies. The need just wouldn't be there. But in rural areas, that the maternity care is needed to be provided. And I think when we think of maternity care, as Dr. Interrante alluded to, it's also preconception care. It's about women's health care, and it's about preparing them for a pregnancy if it's a planned pregnancy, and optimizing their health prior to their conception. But then it's also, very importantly, it's post-conception care. It's following up with these women and their babies afterwards. And we know that the absence of maternity care providers and active labor and delivery services, it impacts not only the delivery of these babies and of these women, but it impacts the pre and post of the pregnancy. For example, women that have an abnormal pap smear that was discovered during pregnancy only because they were able to get enrolled in Medicaid. If we're not catching that in their pregnancy care, and we cannot follow that up postpartum to make sure that they're not developing a pre-cervical cancer lesion or frank cervical cancer, that can be missed if that maternity care provider is not, that women's health provider is not present in that rural location. Another great example is gestational diabetes. Oftentimes, a woman has not had insurance until she gets pregnant and has Medicaid, and she gets tested for diabetes. And the question always is, was this pre-existing diabetes before that we didn't know about, or is this gestational diabetes? And that also needs to be followed up postpartum as well to answer that question and to intervene if this is pre-existing, type 1 or type 2 diabetes that was only discovered incidentally because of access to laboratory services during their pregnancy. And importantly, it's about following up with the babies and making sure that the babies are thriving, that they're getting their vaccinations at 2 months and 4 months and 6 months. So the absence of available maternity care services in a rural area really does impact not only the mother, but it impacts, the babies and the children in that community as well.
Yeah, absolutely. And we, we'll note not everyone here, of course, is in Texas. Texas is one of 10 states that has not expanded Medicaid. So pregnancy is often, the only time that these many adult women are able to get any health insurance. So it's, again, like in Dallas, that's a time to get a lot of health care needs fit in, and the challenge is obviously greater in rural areas. I know in Alpine, in the areas that you're serving, there's always sort of an underlying workforce shortage, workforce stress. I know COVID really stressed that even more so. Can you talk a little bit about sort of the landscape of workforce access where you are, and how COVID impacted maternal health and where we are now?
Yeah, so I think I told you we serve this vast area, about 12,000 square miles is the service area that we serve. And there's about a 25,000 population in this very huge 12,000 square mile area. But we currently have around four family physicians to serve this vast area. We do have one OB-GYN right now. We have one general surgeon and one pediatrician to serve this, this population in this vast area. We also developed, as a way to try and grow our own rural healthcare workforce, we collaborated with Texas Tech Health Science Center more than a decade ago to begin to host a rural family medicine residency program. So we have we have one second year and one third year family medicine resident who train with us their final 2 years of residency training. They spend their first year in a urban academic health center up in Odessa. In a well-resourced quaternary care hospital, well-resourced academic health center clinic, but then they come out to the under-resourced critical access hospital, the under-resourced federally qualified health center, and they essentially grow up professionally knowing how to navigate that under-resourced healthcare environment that unfortunately most rural healthcare systems are. And so it helps them to get comfortable practicing in that environment and knowing when it's time to transfer a patient out to a higher level of care back up to Odessa or to El Paso. And the National Health Service Corps is a federal program that is now about 52 years old. And it was created actually as part of the civil rights movement in the late 1960s. The legislation that came out of that was from 1970. And it was focused just on physicians at that time, to place physicians in medically underserved or health professional shortage areas. But it has now grown to be multidisciplinary to include every primary care healthcare discipline, from social workers to behavioral health providers to primary care providers and others, to really try and place them in underserved communities, whether they be inner city, urban, or rural and frontier areas, such as the communities that I serve. And so I went to medical school on that National Health Service Corps scholarship, and I knew that I wanted to come back to the Texas-Mexico border, and really didn't have to worry about educational debt to return, essentially to come home. And I owed 4 years. I was supported all 4 years for my scholarship in medical school. And so I owed 4 years in return. And I hope it's been a good return on investment for the taxpayer. I'm in year 17 and have no plans to leave, anytime soon, unless I'm asked to leave or I pass away, which I hope neither of those things happen anytime soon. But we have depended on a pipeline through the National Health Service Corps for either scholars that are needing repayment. We currently have 2 physician's assistants that are working with us. One's under the scholarship program and one is under the loan repayment program. Both of our dentists at the Federally Qualified Health Center are on loan repayment. And so it's been a vital source of getting workforce out there, in addition to the residency program as well. And that's another incentive to try and retain these residents when they graduate. But it's been very challenging. But we have been very intentional about hosting trainees, whether they're medical students or PA students or licensed professional counseling students and resident physicians, because we know that, one, they're a workforce multiplier for us. If we have more help in a trainee, it really gives 2 sets of eyes or 2 brains to help think about a patient's condition and help treat and diagnose. And it's created this culture of education and I think a culture of humility within our critical access hospital and our federally qualified health center that I'm willing to demonstrate that I can learn something from a first-year medical student and to just demonstrate that I depend upon that educational process to be bi-directional. I tell each trainee that I hope I'm going to teach you something the time that you're here, but I know that you're going to teach me something, and I want to empower you and enable you that it's okay to correct me if I'm mistaken. But and about 10 over the past 17 years, about 10 of our primary care providers, from whether they be physician's assistants or physicians, they were all trainees with us at some point. And so it's been, very important to have these trainees for multiple reasons, but really for workforce development. During the pandemic, we really struggled, as most healthcare institutions did, and rural healthcare organizations probably disordinately were affected because all of a sudden there were higher paying, high risk, primarily urban COVID units that were popping up, and travel nursing flourished. And you couldn't blame some of our nurses who needed to make a better living. And so we lost labor and delivery nurses that resulted in a 13-month period where we were only able to staff our labor and delivery unit half of the week because of a shortage of labor and delivery nurses. We also lost 5 of our family physicians, 3 of the 5, which were providing maternity care. We interestingly lost them to New Zealand. We had brain drain. These were U.S. trained and U.S. citizen physicians that, obviously our healthcare system had invested in and trained them, and we lost them to another country. So those physicians became international medical graduates for New Zealand to help go staff some of their rural workforce development. And we're still trying to recover. It's been 3 years since the last ones have left, and we still have not been able to replace all of those numbers that we have lost. So it's a constant struggle of recruitment and retention, and there's certainly a place to try and enable our rural students in high school to have an equitable academic chance, as I did, to put on a white coat and go to medical school or dental school or graduate school or nursing school. So thank you.
Yeah, absolutely. New Zealand, how interesting. That's Dr. Interrante, there are obviously these significant challenges facing rural hospitals, especially when it comes to maternity care. What are some of the things you've seen that in like financing and other sort of models that are helping some of these rural hospitals maintain these services, even sort of against the odds, let's say?
Yeah, so again, there's so much talk about like the doom and gloom around it, and there are serious problems, but there's also some really beautiful things happening in rural communities with local birthing care and So we did some case studies to try to highlight some of these rural hospitals and communities that have really bucked that trend and have fought to keep services open. We did one study where we are asking hospitals and maternity care providers, like, why are they keeping services open? And I think there was one quote that really stuck with me that was, I think, really important. It was really about community need. So when nurse told us many of the people who live here are poor and do not have vehicles to go elsewhere. They would come up here to deliver babies even if we did not have an obstetrics department. So again, it's really like trying to fulfill that need locally. And so some of the things that places that have been successful have talked about is recruiting clinicians based off of their mission, not just on funding. So thinking about being able to provide pregnant patients with the birth experiences that they deserve. The full range of services. Again, this requires resources, and I think individuals who are very passionate. Often we see that's one or two people that have really gone above and beyond to try to raise funds and recruit and really like make it special in their communities. But again, offering services like water births and vaginal birth after cesarean, things that even in some urban hospitals are not always supported or available. So again, providing a range of different birth experiences for patients that fit their needs and preferences. We've also heard things like having internal support, so midwives, providing childbirth education and breastfeeding support, even mental health and postpartum peer support groups, helping to not just establish, but supporting existing services and community benefits like that, and connecting patients with other services that might already exist in their community. Even issues around like integration of cultural values and practices in maternity units. We see this, we did a specific case study in rural northern Alaska, where that was a big part of the way that they supported rural Indigenous folks giving birth. Also, they did things like training community members to help be support staff, and it helped lessen some of the staffing difficulties and also increased providing more culturally centered care within the facility. Even some places have started using maternity homes as an option when you live really far out. This isn't something that we see as a lot of examples, especially in the United States, but this is something that is done in other countries as well with large rural populations also. So there are some very innovative and creative things that hospitals are doing, but there's also wider policy angles and changes that have been targeted towards some of this. So I can go into that now if you want to.
Yeah, because I think like, are all those hospitals just sort of saying like, this is never going to make financial sense, but we need to do this sort of morally? Or, I mean, are there ways that hospitals are financially or policy levers that could be pulled to make this make more sense?
Yeah, I definitely think there are policy levers that can and should be pulled to help support this, right? Because well, that may help at the time. If those financial strains continue, there's only so much you can do at that local level. So there are some policies that have been passed fairly recently to address some of this stuff. There was the Improving Access to Maternity Care Act in 2018, and this gets at some of what Dr. Billings was talking about with like professional shortage target areas for the healthcare workforce. So they, HRSA made they identified maternity healthcare professional target areas and have been trying to, again, bolster the maternity care workforce specifically beyond just like finished physicians. There's also the White House Blueprint on Maternal Health that came out in 2022 that highlighted a lot of these issues in rural maternal health and also racial disparities in maternal health outcomes. And part of that also included the Rural Moms Act. That was also 2022 legislation that passed at the federal level. So that provides things like supporting state and regional perinatal care quality collaboratives, again, trying to spread support across systems so it's not just base in one rural community without some external support, especially when you have like higher risk patients that may need a higher level of care. Things like establishing a new rural maternity and obstetrics training demonstration. These are, again, still very early stages, so I think there's lots of potential, but a lot of these have not yet been drawn out as something that's like nationally available for everyone. Also, providing provider-to-provider telemedicine support. So if a rural clinician does have a complication that arises, to have a physician who experiences and handles a lot of higher risk patients that they can connect with, that there are payment systems set up to support that, and that there's relationships established to help, again, support those rural providers and keeping some services when it's clinically appropriate locally. And again, part of this too is improving some of the data around rural maternity and obstetric care, which has been a big challenge to be able to highlight and identify some of what's happening. There's also some other stuff, again, like we really do have to focus on changing state and federal financial policies. There is draft legislation out now that just came out in the last month or two, the Keep Obstetrics Local Act, through the Senate Finance Committee, that does focus on providing things like standby payments. As I mentioned earlier, the high fixed cost of providing services when you have a low birth volume, having some standby payment to help support just the floor needed to maintain services. Also providing things like a low volume payment adjustment in Medicaid, and again, funding for low volume facilities to meet some new safety and quality standards that are coming out is also really important. And I just wanted, if I had time, to mention two more that have been introduced that are bipartisan pieces of legislation. There's the Rural Emergency Hospital Improvement Act that has been introduced in the last few months. And this would help remove, so this comes about in support of the Rural Emergency Hospital designation that came out, that allows hospitals to convert to emergency services, but also when that first came out, it required hospitals to close all inpatient services. And the new legislation that has come out has supported also maintaining obstetric services as inpatient specifically. And also the Rural Obstetric Readiness Act, that was another bipartisan piece of legislation that really focuses on equipment, training, workforce development, and other resources for obstetric emergencies that we know are still occurring in places that have already lost obstetric services. So there is a lot of talk and movement happening, but it's all very early stages. Yeah.
Right. Yes.
Mm-hmm.
Yeah. Well, I do want to open this up to Q&A, and I encourage everyone to put their questions into the Q&A section. We do have a question right off the bat, and from Erica Tricarico, who her question is, what can journalists do to raise more awareness about the impact of closed labor and delivery units on pregnant patients in rural America, especially those with pre-existing conditions? And I'll sort of expand that to say, like, are there stories you all feel like are undercovered specifically? I mean, as well as just the, issue at large.
I'm happy to take a swing at that. I want to thank the journalists that are on this call. This is a teaching point that I use with trainees, is you are part of our healthcare team. We need you to be involved, because you all are the megaphones that can really amplify our patients' struggles and give voice to those patients who may not have a voice, or are Spanish speaking or are non-English speaking population that may not be able to, speak in English and share their challenges. You also share the challenges that our rural healthcare providers have of standing up with clinical courage in under-resourced rural environments because of a sense of, if not me to serve, then who? And so, please reach out to us. We're very busy, but I hope that most, if not all of us, are going to return your call or take your call to begin to share the challenges that we're facing, but also to try and give a personal touch to the why we're doing what we do. And so any of you that do rural stories, it's so needed, and we very much appreciate it. So thank you for being part of our team and allowing us to be part of your team.
Yeah, and if I can add to that too, I say, again, the work of journalists in covering these stories is so important. And us at the Rural Health Research Center, we're not able to just go out and talk to people a lot. We're really like working on the analysis and looking at some of the bigger picture, but without those stories, it's not like the data is not enough to just move things, unfortunately, sometimes, right? You need those stories to be told. And also I think it connects back to our research and the direction of research and the funding of data collection and why that's important, because it's people's lives and people's individual stories. I will say there are some areas like obviously covering rural obstetric unit closures is really important. There are places like in the rural South and majority Black communities that not only have been losing obstetric services, but have not had obstetric services or any healthcare services for a long time. Hospitals that have closed decades ago. That I think is another area that's important to cover. And I would also say in tribal and indigenous communities, what that looks like in terms of access to maternity care services, either through Indian Health Services when the services are or often are not available, and then what it means to have to travel outside of your community just to give birth, and some of the complications around gaining access and working within a system where there is a storied history of challenges from the beginnings of settler colonialism all the way through some of the establishment of different systems that pulled Indigenous kids away from their families. So again, like thinking about what that means to be able to keep those services local and really support tribal customs in giving birth in local communities is also really important. I think one of the areas that has been under focused on as well.
Absolutely, yeah. I will encourage people again, throw your questions in the Q&A section. But Dr. Interrante, maybe you can talk a little bit about, you know, we're having a lot of conversation on the national level about pregnancy complications and pregnancies that are, you know, non-viable pregnancies, these sort of like worst case scenarios. People are, you know, in Texas, as in many other states, you know, being denied care or facing challenges to getting care due to the abortion bans. Can you talk a little bit about how like these pregnancy complications or these sort of worst case pregnancy situations are exacerbated by being in a rural area or being in an area that's underserved by maternal health care?
Sure. And I think some of this Dr. Billings touched on a little bit too, right? It's about the care that happens before you're pregnant and having access to those services so that screenings and treatment, if needed, can be established. Those connections to care, that continuum of care is really important. We also know that half of maternal deaths happen after childbirth. So that's where, again, that the postpartum period really matters. And again, focusing on things other than just maternal death, which is obviously something that should never happen. But there's also other things that are very common that are not studied or talked about that are really important in the postpartum period. Things like urinary incontinence, sleep difficulties that impact mental health and postpartum depression, but also postpartum anxiety and issues around that as well. So again, all of this requires access to services, and access to services requires financial support. So again, thinking about what we value in a society and how are we going to financially support those things that we say we value.
Yeah, absolutely. I mean, Dr. Billings, what does it look like in your community when someone is facing, you know, a pregnancy complication or a hemorrhage or something like that, you know, requires a higher level of care?
Yeah, so if possible, it's transfer to tertiary care or quaternary care hospital, which is an aircraft, a medevac aircraft flight away from Alpine. So it's a 160-mile flight, and it is costly. And it can be dangerous. We have lost some medevac planes that have gone down with patients on board. But oftentimes either there's an emergency or we're not able to transfer out, and so we have to make do with the situation that we have and attempt to transfer when the patient is stable. In the instance of there's obviously not a neonatal intensive care unit at our facility that is also 160 miles away, and so we have to make a call for the NICU team to drive down in a ground ambulance from either Odessa or El Paso, and so it's usually a 3 to 4 hour period before they are arriving. But after being there for 17 years, I have quite a few cell phones of consultants who answer their phones at all hours of the night and day. But it would be very helpful if academic health centers and the payers, both government and private insurers, really helped enable kind of that panic red consult button in every emergency room, every operating room, and every labor and delivery floor, in every medical surgical floor, so that in the isolation of rural healthcare, when we get pushed to the limits of our knowledge, that we're able to very easily create a telehealth consult. That is happening at some rural hospitals, urgently and or emergently, but by far those hospitals are in the minority. And I'm very hopeful that that will be more of a commonality, so that we can try and keep and retain as much of these rural patients at home appropriately when appropriate care is. And it helps to limit some of that rural isolation you have as a rural healthcare provider, especially at 2 in the morning when your patient is getting worse and you just need somebody else to get a quick opinion from.
Right. Yeah, absolutely. I'm going to ask this question from Laura Beal, but Marin Dale, I will also ask you, just if you don't mind putting in the chat, unless either of you know what SDOH is off the top. Are you familiar with that, Dr. Billings? That's not a...
So social determinants of health. Yeah,
I see. Okay.
I briefly saw the question, and
yes.
Yeah, no, certainly the social determinants of health, things like housing and education, though medicine, healthcare is one of those 5 pillars, I believe, of the social determinants of health. We know that what really drives a patient's health conditions are those non-medical drivers of health. Those really impact a patient's health, where they were born, whether or not they have access to housing, food insecurity, those things. And so what I tell trainees is that we are all in the green healthcare pillar, is the slide that I have when I teach about rural healthcare disparities. But it's not enough for us clinicians to be involved in only the healthcare pillar. We have to be involved in the other pillars of the social determinants of health. And the other pillar that I'm trying to impact is, as a school board trustee, is trying to impact that rural education pillar, so that our rural students have an equitable chance to pursue higher education, and especially healthcare education, if that's their dream. So those are so important. And in rural areas, those social services are just so very limited in our rural community. They're part of the limited resources that we have. But we as clinicians, we have to be practicing medicine outside the walls of our healthcare facilities in order to combat those non-medical drivers of the social determinants of health. But great question.
Yeah, and just to add to that quickly, so we see, again, a large proportion of postpartum maternal deaths that occur are not like specifically obstetric clinical related, right? And those are, I think, really under focused on. We see a large proportion of postpartum, like maternal deaths that are happening in the year after giving birth that are related to suicide and homicide, especially around intimate partner violence. And again, I think that's an area that more resources really need to be focused on what that looks like after giving birth. And then a lot of people who give birth already have kids, right? And so having access to childcare and the ability to travel, to cover the cost of that travel, cover the cost of childcare, taking time off work to be able to attend prenatal visits and postpartum visits is also really important to improving maternal outcomes as well. And again, a lot of those challenges are amplified in rural communities.
Right, right. And I mean, this sort of falls under the same social determinants of health conversation, but Dr. Interrante, maybe you can talk a little bit more about the racial disparities in maternal mortality and how that's exacerbated in rural areas.
Yeah, so I think this is where intersectionality really comes into play, where it's not just are you rural or urban, it's not just are you white or black or indigenous or Asian, or do you have private insurance or do you have Medicaid, right? It's the amplification and the interaction of those different situations together that really like increase risk over time. Like these are piling on top of each other to make the risk. Again, we see we've done some studies in the past where we've looked at those three main things like race and ethnicity and rural and urban residency and health insurance status and type. And we see some of the highest rates of severe maternal morbidity and mortality among rural indigenous folks who are low income. And then also very high rates for rural and urban Black folks who have Medicaid and are privately insured. So again, I think a lot of these factors, it's not just one or the other or one versus the other. People are not just one thing or another, right? Like we are the sum of all of our identities and factors that make us who we are and also can impact our health and our access to care.
Yeah, absolutely. This question from D. Hartley, Dr. Billings, I know this is something you think about a lot now in your new role, can you speak to how the number of physicians and residents are limited versus the number of medical students who want to practice? You know, why is this happening? They're asking about the American Medical Association, but just generally, like, what are the barriers to getting the students to go into med school, to specialize in what we need them to specialize in, to get into the residency programs, to stay in the rural area, and like all the way down?
Sure. And I will speak from my rural bias. About 20% of our population is rural in the country. But there's been a 20-year decline in rural origin applicants and matriculants into medical school nationally in the United States, representing now about 5% of matriculants into our nation's medical schools have rural origins. This is really important because the two biggest predictors, or the most significant predictor of a future rural medical practice for a medical student, is rural origin. Rural students are truly underrepresented, we know, in higher education in general. But they are very much an underrepresented population in likely all of our healthcare training programs, from the associate's degree all the way to the physician's degree. But certainly that study by the Association of American Medical Colleges in 2019 demonstrated that it is getting worse. So in my biased view, I really think we have to look at them as a priority population to enable them to have academic success beginning in high school. And to begin mentoring these students, to begin exposing them to different healthcare disciplines. And just as most women in rural areas, they prefer to stay at home to deliver. Many of our rural students, they don't want to leave their families to go to higher education. They don't want to have to leave their familiar environment, their social connections that they have. And I think we need to be very intentional about development of rural academic health centers that are multidisciplinary and likely multi-institutional, from the community college all the way to the academic health center, to train, at least in every state that has a rural county, which there's 47 states in our country that have rural counties. I I believe that we need to advocate for the development of rural academic health centers where we can create a rural train-in-place educational model for these students that want to train rurally, because they are the ones who are most likely to stay home or serve in a rural area. We know that there's significant attrition to urban areas when our rural students leave for higher education. They stay perhaps longer for dental school or medical school. They meet partners who don't have those rural roots. And so it is much, much more difficult to get them back. The second biggest predictor of future rural medical practice is exposure to rural medicine while you're in medical school and or residency. And I also believe that we need to do a better job at creating more rural residency programs in our rural areas, but also just getting every healthcare training student out for a portion, but in my biased view, all of their training to be done rurally, again, so they're experiencing this rural under-resourced healthcare environment. And the idea is that I don't believe that we should have to use rural and under-resourced environment. I think the more that we train these students rurally, they're going to build up the resources. And perhaps one day I dream of a world where we're not speaking of rural under-resourced environment, that there's an equitable healthcare outcome, whether you're a rural patient or you're an urban patient. And unfortunately, that is just not the reality of today.
Would you talk, you alluded to this before, but talk a little bit more about this idea you and I have talked about of like clinical courage and like what it takes to practice in a rural area?
Yeah, so clinical courage is a concept that was developed out of the Australian and Canadian rural medical literature. And it's really talking about the sense of purpose and the sense of calling that really allows a rural clinician to serve and to sustain oneself in a rural under-resourced environment, is to practice without all of the tools of our trade that we need, whether it's not being able to get a laboratory result immediately. It may be a send out and you may not get the result for 72 hours. Or perhaps you don't have an MRI and you need an MRI. And knowing when and where it's time to send a patient to an urban area. And when there's a bad, and having a network of consultants that you can reach out to get help when you need help, to get some additional training when you need that additional training. And when there's a bad outcome, sometimes because of the lack of those resources, the courage and the ability to stand up again and say again, if not me to serve this patient, this community, then who? And that clinical courage is certainly something that is really important to try and foster in our healthcare training students. And I think it is something that the rural-born student brings, that has this sense of community and that may be caring for their former teacher or their former pastor or their current pastor. They just have this sense of purpose, this sense of mission, this sense of calling. And certainly I view rural clinicians as their domestic missionaries, trying to meet the need in a very challenging environment, because they again have this sense of calling to be there, to stand up and to serve. So yeah, clinical courage.
Yeah, no, I think that's a very powerful idea for rural areas. There's a couple other questions that we may have time to get to, but one thing I do, Dr. Interrante, I want to make sure we sort of arm journalists with before they leave this panel is, what are some data sources? Where should people be looking for reliable information about this issue as they want to dig in deeper?
That's a great question. And as I mentioned earlier, the data can be really hard, right? It's limited in rural areas. A lot of national sources of data don't let you see smaller levels of geography, including even just rural versus urban. Again, there are data privacy issues, but there's also a need to be able to see what's happening in rural communities to address the problems, right? I think the federal government has been working on making some of this change. Like they have been trying to make more things available with national data sets on long rural and urban lines. CDC has their new Office of Rural Health, and they've been trying to put out like basically cuts of data on maternal health outcomes on rural and urban lines now. So again, I think there's been better focus on this. Some of the data sources that we use are like require money to pay for to be able to use some of the data. I think some of the richest data sources are really expensive to get access to, like claims data, and it's not easily accessible. And requires like knowledge of statistical software to be able to analyze, right? But there are things that are available, things like the county health rankings that have some health indicators. CDC Wonder has a lot of great information on natality, so birth records and death records. Again, more of this stuff is becoming available to be able to look at in rural and urban lines on a national level. I will say us at the Rural Health Research Center, we do publish a lot of our studies, not just in peer-reviewed journals that are behind paywalls, but as policy briefs and as case studies that are publicly available on our website, the Rural Health Research Center. So, and there are also other rural health research centers that are funded through the Federal Office of Rural Health Policy like us, and the Rural Health Information Hub is a great source where all of the data is pulled together. So a lot of research around rural health is available there as well.
Fantastic, thank you. Yeah, that is always a little, imperfect, but one last question that I will throw to Dr. Billings, but then also, Dr. Interrante, if you have thoughts on sort of the national level. This question is about, what are some of the trends that Texans aren't aware of about the state of maternal health care in Texas? So Dr. Billings, if you want to talk about Texas, and then maybe Dr. Interrante, if you want to talk more broadly about the national perspective, and then we'll have to leave it there.
In spite of the challenges, I remain very hopeful that there's more and more of a recognition of these rural health care disparities, and especially a recognition that we need to be investing more in women's health care. But we can't just sit back and have blind hope and faith without doing the extra hard work that it requires to make women's health care a priority. And so we all of us, we have to be involved in the political process. We have to vote, and we have to get others to get registered and enable them and help them to vote when it's time to vote at the community level and at the national level and everything in between. We also need to be that healthcare resource for our elected officials. We want them calling us, I think, as healthcare providers, because we have the altruistic perspective to give to a patient, and we have that fiduciary interest in our patients to do right and do the best for them. But also, we need to be part of the political process, and we need more healthcare professionals running for politics as well. But certainly, we have to engage in the political process. We cannot just sit back and watch and hope. But I remain hopeful in spite of the challenges. And what policymakers need to hear is these patient stories that you all, the journalists in the audience, can so passionately tell. We can give data all day long, but often what changes minds and hearts is these anecdotal patient stories that you all give a voice to.